The 45-year-old male patient is at risk of suicide. The immediate plan is to secure a plan of safety. The plan, of course, would be dependent on the patient's responses and his perceived actions. I will explain more in detail as follows. The first action is to secure the patient from having access to any weapon or potential weapon he can harm himself with, or others in any which case, especially since this is indicated in the scenario. After asking the patient who is a close resource, such as a close friend or family member, I would provide the patient with an ROI to release information to the individual he indicated per his social support and get on the phone with that person while the patient is in the office so that we can all together discuss a plan of safety and how to proceed with securing safety measures. I would reiterate that the gun in which was indicated by the patient is removed out of his possession and reinforce with the patient's designated support member to make sure he or she keeps the gun in their possession stored away securely. Then I would start the patient out on lithium, 300 milligrams for the first week. I would caution the patient that the lithium prescription requires labs to be run and a disclosure previous to placing the patient on the medication. I would ensure that there are no serious contraindications, such as kidney disease or failure. And if the patient was on ACE inhibitors or a hydrochlorothiazide or any NSAIDs, I would get them off of that, off of those drugs, or any drugs that are inhibit or induce medications, and before immediately starting him on that. I would instruct the patient to take 300 milligrams at bedtime. I would schedule a follow-up within 1 week of starting the medication to evaluate the patient. Again, based on the patient's response, my plan would be altered. But let's say he's doing better after bringing him into the office the following week. I would increase the medication to 600 milligrams at bedtime once daily. I would bring the patient back again in 1 week and assess how he has been doing. If he's doing better, I would order labs for him to get done as soon as possible. And these would include a CBC, a CMP, a TSH with reflex T4, along with a lithium level. Since the patient does not have a history of mood disorder, I would make sure the lithium levels are between 0.6 and 0.8. But if an existing mood disorder is present, then I would make sure the levels are between 0.6 and 1.2. If the labs are all within normal limits, I would keep the patient on the lithium and I would increase it to 900 milligrams at bedtime once daily for 6 months before consideration to wean off. And as I'm weaning off, I would wean it off in doses of about 150 milligram doses of decrease per each week. Now, let's say the patient refuses to take the medication for various reasons. I would advise the patient to admit himself to an inpatient psychiatric unit. If the patient agrees, I will have his friend or support system escort him from the office and to the patient's home to gather his necessary belongings and to be taken to the psych facility for his temporary stay. If the patient refuses, then I would fill out a Baker Act form explaining to the patient why it is necessary and have the necessary authorities pick him up from the office. Of course, this scenario has multiple variables, so it's important to gauge the plan by the patient responses. But in general, I would administer a Columbia Suicide Severity Rating Scale during the time of the visit and at each visit as well. And I would use that as a measure to assess the patient's symptoms and the current conditions. The scale is designed to measure suicide ideation severity and suicidal behaviors with two subsets of items. The first subset captures past month severity of suicidal ideation. The second subset measures past 3-month presence of actual and aborted suicide attempts with one item on a nominal scale.